Hello, everyone. My name is Jeffrey Kaufman. I'm the Executive Director of the Adenoid Cystic Carcinoma Research Foundation. I'm incredibly honored to have been invited to speak at the Head and Neck Molecular Tumor Board International Conference. I'd like to thank Dr. Chen Zhaohong and the other organizers of this conference for the invitation. Today, I'll be speaking about identifying therapeutic strategies for adenoid cystic carcinoma through tumor profiling. I'm going to start my talk with a quick overview of our foundation, and I'll discuss the disease, adenoid cystic carcinoma, and the genomics that underlie it. I'll then speak about biomarkers of aggressive disease, passengers in the surfaceome that are coming to the fore in treating this disease, as well as matched therapies that are in development for ACC. And then I'll finish up with the summary. Starting with an overview of our foundation, the Adenoid Cystic Carcinoma Research Foundation was formed in 2005 in the United States by my wife in the picture here, who was diagnosed with ACC in her right parotid gland. We early on decided we had a mission to accelerate the development of improved therapies and a cure for ACC. And in the 19 years since we started the foundation, we've given grants to more than 50 academic researchers across the globe, including 3 in China. We've developed a preclinical screening platform of our ACC models that are open to all academics and all biopharma companies. And we educate patients about their disease, what their treatment options are, and appropriate clinical trials for them to try. So ACCRF is really here to help researchers in any way we can. So please, if you have a project that you're considering, feel free to email me or our Director of Research, Nicole Sparty-Burr, and we'll help you in any way we can. Now, turning to ACC as a disease, the epidemiology, really, this is a secretory gland malignancy. It's usually thought of as a salivary gland cancer, but it also shows up in other sites, 80% in the head and neck region, such as the lacrimal gland or sweat glands. About 12% of ACCs are in mammary glands. So really any secretory gland. There are about 4 cases per million people every year, and there are about 35 patients living with ACC per million. The histology and prognosis of ACC is unusual. The histology is broken down into 3 types. There's tubular and cribriform, which involve both epithelial and myoepithelial cells. And then there's the solid histology, which is almost completely epithelial cells. There's frequent perineural invasion ACC, and the markers of poor prognosis are stage, solid histology, 1p deletions, and activating notch mutations. The mainstay of treatment is surgery followed by radiation, and that leads to very good local control in about 90% of ACC patients. Unfortunately, distant metastases do come about in about half of ACC patients, usually to the lungs, but sometimes liver and bone. The overall survival rates are pretty good on a shorter horizon, but really drop substantially when you get out to 15 years to well below 50%. There are no approved systemic therapies for ACC patients with metastatic disease, though the unofficial standard of care is gradually shifting to VEGFR inhibitors. So the genomics of ACC, the hallmark genetic alteration is a translocation that brings together the MIB gene, oncogene, and the NFIB gene, or the NFIB gene and the MIB-L1 gene. These translocations occur in about 70% of ACCs, and the mechanism by which they work is that the translocation brings a super enhancer that's right next to NFIB close to the MIB locus. And that creates a feedback loop whereby MIB or MIB-L1 expression is upregulated. And at least 90% of ACC tumors have very strong MIB or MIB-L1 expression. Now, not all of them actually have a fusion. It may be the case that translocation just brings the super enhancer near the MIB locus, but not, it doesn't create an actual fusion gene. You can actually have upregulation of wild type MIB or MIB-L1. ACC genomes are, there's very low mutation rate. So these are immunologically cold tumors with low PD-L1 expression and low tumor infiltrating lymphocytes. Notch1 mutations occur in about 15% of primary tumors. And what we've seen is that these tend to be tumors with much more aggressive courses, and the overall survival is much shorter. It could be perhaps 2.5 years from diagnosis for a Notch1 mutated patient versus perhaps 10 years overall survival for a non-Notch mutated patient. Looking at the landscape of genomic alterations, perhaps a third or half of ACC tumors have a wide array of chromatin remodeling factors that are altered. These would be like KDM6A or ARID1A, and the mechanism isn't very, very well understood. There's also a wide range of genes with low rate of mutations in the 2 to 5% range. So given that MIB is the main hallmark alteration in ACC, you would think that would be the most important gene to look at for matched therapies for ACC. Unfortunately, there are no approved drugs that target MIB at this moment. Also, given that MIB is almost always expressed in ACC, certainly the trials we've seen generally, if the drug is thought to be targeting MIB, then there really isn't any need to stratify because basically all the patients will have MIB or MIB-L1 overexpression. Thus far, there's really only one therapy that's specifically targeting MIB, and that's a MIB DNA vaccine, where there's a trial at the Peter Mac Cancer Center in Melbourne, Australia, and we're anxiously waiting to hear those results. Fortunately, there are multiple other companies that are developing small molecule inhibitors of MIB that work by disrupting RNA processing to create an altered MIB transcript that is rapidly degraded. So we are aware of at least 4 companies in this space. Now, the location of the poison exon may require some patient stratification in future clinical trials. As you can see, what will happen is that these drugs will modulate the RNA in such a way that they create a poison exon, which is then more rapidly degraded. The question is where is this poison exon? And in the vast majority of ACCs, in fact, every ACC that's ever been analyzed, the first 8 exons of MIB or MIB-L1 are retained. So if there were a drug with a mechanism of action that were to work outside of that, it would be necessary to know if that is the case, because then there would be, it would make sense to identify patients who perhaps would not be appropriate for this particular drug. So I guess the point is that tumor profiling, in the future may need to be customized to the specific drug mechanism, perhaps which exons is it targeting, and the specific gene fusions of individual patients. Now, as far as these match therapies for MIB, one is about to enter clinical trials within the next month or month and a half. That's RMX-422. And we are aware of at least one and perhaps more MIB inhibitors that are expected to enter clinical trials in 2024 and 2025. And we're quite excited about these MIB inhibitors. As you can see on the left is a tumor growth inhibition study in one of our patient-derived xenograft models. And I'll say that until the last year and a half, we never saw very substantial tumor regressions in the majority of our mouse cohorts, and yet we've seen that here. So we're very excited to see whether this activity that we've seen in preclinical models can be recapitulated in human clinical trials. As you can see on the right, it's nice to see that the activity was very highly correlated with a very significant drop in MIB expression in the vehicle into the treated tumor. And so another reason for great optimism that this is mechanistically working as you would expect it to. Now, there are other biomarkers of aggressive disease in ACC. MIB is typically viewed as sufficient for tumorigenesis and indolent growth, but there's clearly a subset of patients, about a quarter of recurrent metastatic patients, who have much more aggressive disease. And the historic marker of that aggressive disease was solid histology, just doing an H&E slide and looking at the histology. And that certainly is still widely used as a marker of aggressive disease. Several years ago, our grantees at MD Anderson identified the Notch1 gene as a marker of very aggressive disease, particularly when there was an activating mutation as determined by next generation sequencing. And you saw that the overall survival, as I mentioned before, could be 2.5 years for a Notch1 mutated patient versus 10 years for patients without the Notch1 mutation. We've also, this activating mutation was a biomarker used as an inclusion criteria for the Notch inhibitor trial of AL101. There was another Notch inhibitor trial in ACC for CB103, and it used a slightly different biomarker. It was also looking at Notch1, but it was looking at diffuse NICD staining. So this is an IHC approach rather than an NGS approach. Often they did have both the IHC and the NGS, but in certain cases, there were patients who went on the study just based on the diffuse NICD staining. There's also fairly long-standing and validated literature on the importance of 1p deletions in ACC. And what you're seeing is sort of a melding together of these and some other biomarkers of aggressive ACC into a newer categorization of aggressive disease, this ACC1. And at MD Anderson, they came up with a categorization where ACC1s were the more aggressive diseases that were highly correlated with solid histology and activating Notch1 mutations. And then there's another category, ACC2, which was not and had a much, much better prognosis. And as you can see below, ACC1 here in the red has a much shorter overall survival, while ACC2 patients have much higher overall survival. ACC2 tends to have at least some, if not a great deal, of P63 staining, which is stain for myoepithelial cells, while ACC1 tumors have very, very little P63 and generally have more MYC. And so, clearly, these biomarkers are, if they're not being used as inclusion criteria for a Notch inhibitor as they have in the past, certainly they're being tracked closely for unselected trials, for all comer trials to determine whether there might be differential response to therapy based on these biomarkers. Now, up until now, we've been talking about MYB and Notch, and both of these are well-known oncogenes, and so they're clearly drivers of either indolent ACC or aggressive ACC. What we're seeing out of a lot of fascinating research is that there are plenty of passenger alterations or overexpression in ACC that can serve as very, very important targets for therapy. And clearly, tumor profiling of these targets is a really important part of treating these patients with the appropriate drug. So again, out of MD Anderson, there was a very important paper that identified quite a few cell surface markers that were overexpressed in ACC, and they correlated that expression with whether they were more common in the ACC1 aggressive ACCs or ACC2, the less aggressive ACCs. And you can see here there are some really interesting targets like B7H4, AXL, EGFR. And so what we're seeing is an explosion of new targets that may be applicable for ACC. Certainly PSMA is a cell surface target. That there's already been some clinical trials looking at radioligand therapy or PSMA CAR T therapy. We just got our first readout from a radioligand therapy study that ACCRF supported in the Netherlands. Unfortunately, there was not a great deal of activity. However, there are many other very exciting targets, B7H4, AXL. B7H4 is expressed in ACC1 in particular, and AXL is expressed particularly in the ACC2 tumors. What we've also seen is that TROP2 tends to be expressed at a moderate level in both ACC1 and ACC2. And we've seen some other targets like LGAL S3BP that's expressed in a subset of ACCs. And so these are all targets that are really taking off, particularly for antibody drug conjugates or ADCs. And what we're seeing as they go into the clinic is that there is selection of patients based on the signature, whether it's ACC1 or ACC2, that's a very important and welcome development. So turning to B7H4 inhibitors, ACCRF worked with AstraZeneca and MD Anderson, and we saw in our ACC1-like patient-derived xenograft mouse models, strong expression of B7H4. We treated those models with AstraZeneca's B7H4 ADC. And what you can see is that there were very, very strong regressions compared to the control mice. So we're very, very excited about this possibility. And we've already have CGen has opened up and put some ACC patients on their B7H4 inhibitor at this point, and we're anxious to see how those patients do. Another important cell surface marker is AXL, and what we've seen is ACCRF collaborated with ADC Therapeutics to generate similar preclinical data. We saw expression in our PDX mod, in some of our PDX models, the ones that were more ACC2-like. And again, you saw very, very good regressions in those PDX models treated with the AXL ADC. There is a company called BioAtla that has recruited a fair amount of ACC patients, and again, we're anxious to see that data come out. I mentioned before TROP2. There it's more. There's definitely expression of TROP2 in ACC. However, it's also somewhat heterogeneous. There's some models and some patients don't have any TROP2 expression, but there are actually two clinical trials, one from Gilead and one from LegoChem, that are currently open to ACC patients. So again, we're anxious to see that data. Just a quick summary, as I mentioned, CGen has BioAtla, Gilead, LegoChem, and we're expecting Astellas to have a Nectin-4 ADC in clinical trials fairly soon. And there may be several more opening in the coming year. And what I will say is that often there are not inclusion criteria because there's a question of how much expression is necessary for there to be activity. For example, with the HER2 ADCs, we saw that even modest expression of HER2 led to activity with HER2 ADCs. And so I think a lot of these companies want to start with an unselected approach where even if there's low expression, they want to see if their drug will work in those patients. But absolutely, these tumors are being stained, and so they're going to try and correlate expression with activity of these markers. So in summary, I think biomarker strategies and understanding the tumor profiling, whether it's by NGS or IHC or FISH even, or really any whatever the approach to tumor profiling, we think it's really, really important that even if we're not at a stage where that profiling is being used to stratify patients, we think it could be very important in the future once we have more data and we get past the proof of concept phase 2 trials. And so I think even with a hallmark genetic alteration like MIB, we may need to have some tumor profiling to match the appropriate therapies. So does a patient have a mid-NFIB fusion at with a breakpoint that is perhaps exon 9 or 10, and yet there may be a therapy that requires exon 10 or 11 that just isn't there. And so that patient might be left off or excluded from the study. So those types of scenarios I think will be very important if these drugs prove effective. Likewise, for markers of aggressive disease like Notch, mutations, NICD, P63 staining, these are already important for stratifying patients for Notch inhibitors. And I think they're being integrated in all new trials, so they, even for unselected populations in the future, they may become important biomarkers for stratifying patients. And as I showed you some exciting data on the B7H4 and AXL preclinical data, clearly these passenger biomarkers that are not drivers, they're not drivers of the disease, but they're incredibly important biomarkers, and the tumor profiling of the patients will be absolutely crucial to making sure the right patients get the drugs and have activity with those drugs. I really want to emphasize that the preclinical data that we've seen with both the novel MIB inhibitors and the various antibody drug conjugates, that data that I showed you is by far and away the best preclinical data we've ever seen in probably about 15 years of screening drugs preclinically. So we're incredibly excited about the opportunities that are really opening up for ACC patients, and so it gives us a lot of hope for the future. And I'd like to finish with really a call for unity. I think that all of the advances that we've seen in ACC research are the result of a global effort, global basic research, global translational research, and global clinical research. And for us to keep this progress going, it really does take a global effort that spans many countries, many institutions, and many laboratories. So I want to continue working together with you all. Again, I want to thank the organizers for inviting me to speak at this wonderful conference. And I look forward to communicating with all of you who have an interest in moving forward with ACC and other head and neck cancers. So thank you very much for your attention, and please enjoy the rest of the conference. Thank you.